Hello from Australia. Firstly, I want to congratulate Clive and the Immunopaedia team on the 20-year celebration of the project. Thank you so much for inviting me to reminisce about my journey, which spans the origins of our efforts to address HIV in pediatrics since the mid-90s and across continents from South Africa to Asia. I'm very privileged to have lived in three wonderful countries. I grew up and worked in Johannesburg, South Africa until 2012, and then moved with my family to Hong Kong for the next 6 years. Since 2018, I've been living in Sydney, in Australia, where we traditionally acknowledge the land of the First Nations people. And today I come to you from the land of the Gadigal people of the Eora Nation, whose land was never ceded, and I pay my respects to elders past and present. I trained as a pediatrician at Chris Hani Baragwanath Hospital in the 1990s and then continued to work as a consultant. During this time, Barra was a 2,800 bedded hospital and was in the Guinness Book of World Records as the largest hospital in the world. At the time, we had 4,000 annual admissions to pediatrics. When I first started my training at the beginning of the 90s, we saw only a handful of children with HIV. But by the time I qualified in 1996, the wards were inundated with HIV cases. And in 1996, I conducted a serosurveillance study which showed that almost 30% of admissions were for pediatric HIV-related conditions. And this was not surprising. From 1990, South Africa conducted annual sentinel surveillance of pregnant women attending antenatal clinics across the country. And this figure shows the steep rise in HIV prevalence amongst pregnant women over the 90s, eventually rising to around 30% in the early 2000s. And this rapid rise was reflected by the increasing pediatric cases that we were seeing in the wards. At the time, there was no antiretroviral treatment available for prevention of mother-to-child transmission. And as a result, about 30% of women would transmit their infection to their infants. At the time also, women were not routinely tested during pregnancy, and so often the admission of their babies became the first time they would be aware of their own diagnosis. And the children were sick and the outcomes were poor. But at the time, during the 90s, already we were aware that antiretroviral treatment could not only prevent HIV infection from mother to child, but also by 1996, evidence was available that a cocktail of treatment could alter the course of disease. But at the time, the cost of treatment was very high, and it was unimaginable that people in poorer countries would ever access treatment. By 2000, of the 34 million people that were infected, most of whom were in sub-Saharan Africa, there was less than 700,000 people accessing treatment, and these were mostly from rich countries, with less than 10,000 in sub-Saharan Africa. In 1998, I was privileged to do a postdoc fellowship at Columbia University in New York and had the opportunity to visit a colleague's clinic in Harlem where children were receiving antiretroviral treatment. And the benefit of treatment in these children was remarkable. Most of them looked like any ordinary children and were full of life. On returning to South Africa, I began to lobby for antiretroviral treatment to become available in our country for our children. And then when I returned to South Africa, it was also starkly obvious how sick children still were, and we were still faced with the high mortality from the disease. But growing civil action led to the big pharmaceutical companies eventually releasing patents for their medication, and generic drugs could then become available legally. But there was still no commitment from governments to provide treatment on a wide scale. Like Clive, in the early 2000s, I received an Elizabeth Glaser Pediatric AIDS Foundation International Leadership Award, which allowed me to support a small treatment initiative. And we began to provide antiretroviral treatment to a few children and develop experience in treating these kids. Despite ongoing AIDS denialism from the president and health minister in the country at the time, eventually the South African government made the decision to provide antiretroviral treatment to all from 2004. And in clinic, we were ready to start this. We were able to witness the dramatic effect of antiretroviral treatment on the lives of the children that we were treating. During this time also, we had renovated a clinic at the hospital, and these are some of the patients and their mothers who attended our clinic. Many of these people, our patients and their children, suffered from stigma and had many challenges in their lives. But these two brave women we helped to achieve treatment and for themselves and their children, and they were brave enough to advocate for other women and also become peer counselors in our clinic. By 2005, a year after the rollout of treatment, we had started 1,000 children on treatment, and this was a celebration to mark the milestone of 1,000 children receiving treatment. In the years that followed, we managed to treat more than 6,000 children on antiretroviral treatment and became one of the largest HIV services for children in the world. Despite availability of effective and cheap regimens for prevention of mother-to-child transmission over the late 90s and early 2000s, South Africa dragged its feet to roll prevention of mother-to-child transmission treatment out. And in the early 2000s, a group of us pediatricians launched a campaign called the Save Our Babies campaign. And this ended up in a ruling by the Constitutional Court of South Africa that forced the government to provide treatment to all HIV-infected pregnant women. Despite this, it took many years before this could be fully implemented. But the program, by the late by 2008 to 2010, eventually demonstrated enormous success with a reduction in mother-to-child transmission to below 2%. And globally, the progress in prevention of mother-to-child transmission had been so successful that by 2011, United Nations member states agreed to target prevention of mother-to-child transmission to reach a goal that would see negligible numbers of babies being infected. And it was at this time that I moved to Hong Kong and began to consult with WHO in Asia, who were working on these elimination goals, and Thailand and Malaysia became among the first countries to achieve this milestone in the region. In my time in Hong Kong, I worked with WHO on an elimination of mother-to-child transmission program and roadmap for a dual elimination program for the prevention of HIV and syphilis. And the Western Pacific region also decided to include hepatitis B in a triple elimination program. and framework, which became the basis of a global triple elimination framework that exists today. Since moving to Australia in 2018, I continued to consult to WHO and was a member of the working group on updating recent hepatitis B and C guidelines. I also work clinically now in youth health with youth from disadvantaged populations and also at the Aboriginal Medical Services in the inner city. I also am still involved in research and at UNSW work on health services research. But I remain committed to the elimination of the bloodborne viruses. So I want to thank you all today for listening and enjoy the rest of the meeting, and really sorry that I can't be with you all today.